Good evening, everyone. Thank you for being here today. If you are new to our speaker series, my name is Pauline Matindan Garcia. I am the Director of Care Transition for Livingston Memorial VNA and Hospice. I have been in a home health and hospice care setting for about 10 years now, and I've been fortunate and proud to be part of the Livingston team for about 3.5 years. As Director of Care Transition, my role is to work closely with our care providers out of the community as they help their patients navigate options for home care. And I am really proud and feel fulfilled that our patients out in the community are able to access medical care in the comfort of their own home through Livingston. So I will be moderating tonight's presentation. Tonight's topic is how can hospice help? But before I introduce our speaker, I want to go over a few just housekeeping items. First, today's session will be recorded and will be available for viewing post-presentation. If you have any questions, comments for our speaker, please feel free to use the chat function on the bottom portion of your screen. We will do our best to answer all the questions that you have. Otherwise, all the questions and answers will also be posted on their website after the presentation. And lastly, if you run into any technical issues, please feel free to send me a message directly using our chat function as well. So tonight's speaker is our very own Terry Helton. She is a registered nurse with a master's degree in nursing education from Mount St. Mary's College. She currently works for Livingston Memorial as one of our community educators, actually our primary community educator. Her life experiences in faith communities and as a nurse working in long-term care and hospital settings, hospice were really the root of her passion for sharing the importance of initiating the conversation regarding advanced care planning and end-of-life care. Terry also works with Ventura County Coalition for Compassionate Care as part of her commitment with community service. Terry is a longtime resident of Camarillo. She loves and enjoys traveling with her husband to spend time with her grandchildren and looking forward to an upcoming trip actually to Hawaii. So without further ado, here is Terry Helton.
Good evening. It's good to see everybody, so to speak. Webinars, video are fun, but they have actually been a great advantage in the last couple of years and something we want to hold on to. So I am really looking forward to this conversation tonight, and I would welcome questions and thoughts as we do this. More of the questions at the end. I have been teaching about hospice for quite a while. I was a hospice nurse, and I actually miss it most of the time, but it's a very, very important time in people's lives. And I want to take care of any misconceptions that people have about hospice, and there's a lot of them out there. So I'm going to begin with what Dame Cicely Saunders said. And by the way, Dame Cicely Saunders was a person that I could, as a Hindu person might say, I could take the dust from her feet, because not only was she a nurse, she had been a psychologist, she had studied physical therapy, she became a physician, and she started the hospice movement in England before we had a hospice movement here in the United States. And that was Elizabeth Kubler-Ross that went with her, met her, brought her over to introduce the idea here. So she was an amazing lady, and I'm going to quote her right now. "You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to live until you die." And that's a point I want to make about hospice. It's not about the dying. It's about how you continue to live in that process of dying. And I'm going to be frank. We are all dying at some level. Bad news is we're born. Bad news is we die. So our objectives this evening are to define hospice care, understand the hospice care team, understand what Medicare covers for hospice, and discuss how to know when someone is ready for hospice. And part of that is for hospice, recognizing, next slide. We want to recognize that dying is a normal and natural process. As I said, we are all born, and that's a natural, normal process. And for some reason, we think that dying isn't. We have it in our conscience that it's not something, and it isn't something I want to do today or tomorrow or next week or until I get back up from Hawaii. But it is a natural process, and it is something that we are all eventually going to do. And what we know is if we can normalize this conversation, it helps diminish fear, and it helps us to have conversations with our family that are important to have before a time comes when we can't make time for those conversations, or we have the inability to have conversations. So another important part of hospice is it neither hastens nor postpones death. So a lot of people think that when a person comes on hospice, hospice's job is to help them die. That is not true. The job of hospice is to help that person have as much life as possible while they're on hospice. We don't give them medication to make them die, and we don't take away their medications. As a hospice nurse, I would go into a patient's home and review what medications they had there. I would look at them, write them down, have a conversation, call a physician, and have a conversation about these are the medications. What do you think? And let's say we have somebody who's really close to the end of their life, maybe 4, 5 months, and they have joint pain, and they've been taking a medication that may have, they're taking an anti-cholesterol medication that might be causing their joint pain to be worse. So that conversation might be, well, if we stop this medication, you might have less joint pain. That's the kind of conversation that is meant to say, let's help you have life. So the idea, again, is to not postpone death and not hasten it, but to make life worth living. So affirm life, provide support, and care to promote that life. And then an important part of the job of hospice is to provide comfort and symptom relief. So comfort is all-encompassing of beyond pain, and we'll talk more about that as we progress, but that to make sure that they are comfortable as they can be, and that we relieve symptom pain, which is not just pain, but it is also shortness of breath, it is anxiety, it is stomach issues, maybe skin issues, wounds. So it is also a time that we want to provide special time for individuals and loved ones. So we will talk more about that as we progress. It's important to know that hospice takes place where the person resides. Hospice is a philosophy. It is not necessarily a place. Way back in the 80s when hospice was established from Medicare, there were many places that actually offered hospice facilities because we had an AIDS epidemic going on, and they would make these facilities for people to go to and provide care. But that is not the norm throughout the country because it is so expensive to run a home for people who are dying. We have one locally in Santa Barbara, and there is one in LA, but it is such an expense that is very difficult to do. So knowing that, it is always good to know that we can have hospice in our home, in a board and care, in an assisted living center, and even in a skilled nursing facility. And there have been times when hospice has been provided to those who are on the street, and hospice will help them find a facility to live. So these are possibilities to know, and that hospice is where the home is. Hospice covers various diagnoses, including cancer is what we often have come to our head, AIDS that I just spoke of, but also end-stage cardiac disease, end-stage pulmonary disease, that's lung disease, Alzheimer's and other dementias like Parkinson's, end-stage cerebral vascular disease, which could be the effects from a stroke, It could be the effects from different mini strokes that are taking away the memory. And it covers other things such as ALS, also known as Lou Gehrig's disease, multiple sclerosis, kidney or liver failure, so multiple kinds of diseases, diagnoses. Hospice care comes under the Medicare rules. And I'm going to try and remember to explain something after I cover this slide, and it's very important that you understand this. So individuals must have a life-limiting illness, and we'd like to say they have a terminal illness, but that just sounds so negative to me. So they have a life-limiting illness. We would not be surprised if they died in 6 months. And in fact, the Medicare says that their diagnosis says they will probably die within 6 months. It requires a licensed medical practitioner order, such as your primary care physician writing that order or your specialist writing the order. The individual does not have to be homebound. Now, if we were going to talk about home health care, that person would have to be homebound, meaning they could not go to the theater, they couldn't go out to eat, they could go to the doctor, they could go to church maybe. So in hospice, it's the opposite. They do not have to be homebound. If they want to, and they have the strength, they could go out to the movies. They could go to a play. They could go out to eat as much as they want. They could go golfing. They could go to the park. So I say that in truthfulness because we also want that person to be able to travel if they can. And there's limits to that. But I will tell you the story of the gentleman who had liver cancer. And he had been married for a few years to his wife, and his diagnosis, he says, I do not want treatment, and she was a nurse and they were in agreement with this. But they were going to celebrate their anniversary, and so he decided he wanted to go see his family in another state. And he talked to me and we talked to the office, and they set up a contract with the hospice in that other state. And they took a trip to the other state and had hospice care there. As it happened that the pharmacy here did not supply enough of the medication for him to travel with. And so when he was in that other state, he called and said, I ran out of lactulose. And we said, we'll take care of that. We contacted the hospice in that other state. They ordered that medication and had it delivered to him, and he continued his vacation and came home. Now, saying all that, if a person is going to travel to Hawaii, like I did, they're not going to have hospice in the air. Now, they could have hospice in Hawaii, and they can't go to a European country or to internationally and have hospice. That benefit is only for the contiguous United States. But it is a benefit, and it's something, that it just shows how we want a person to have as much life as possible. So there is, and I'm going to say that the doctor, the physician, and the director, the medical director for that hospice have to agree on that diagnosis. And we know that it's good for 90 days. And then in 90 days, they revisit and say, is this person still on hospice? Can they stay on hospice? And they recertify for 90 days. That's the 6 months. Well, lo and behold, we come along and it's been 6 months, and now we're going to look at this person and say, my goodness, they really are still declining. They have a cancer that's going to take their life. It may not be in the next 6 months, but they are declining. They're not getting any better, they're getting worse. So they can stay on hospice for another 60 days. And then every 60 days, they look and say, how is this person doing? Are they still eligible to stay in hospice? And normally, every 60 days, it will get recertified. The certificate for recertification is done. Now, there are times that people will look and say, you know what, you're actually better, and I need to discharge you. And I did have this happen with more than one patient. I had a gentleman who came on care for a pulmonary heart problem, his lungs and his heart. And when I went to visit him, his lungs were so full of fluid. And I looked at the medications like I described earlier, and I went through them and we discussed them. And then I called Dr. Dial and I said, these are his medications. This is my thought. What do you think we should do, Dr. Dial? And he said, has he ever been on such and such a medication? And I said, no, he has not. And he said, well, let's stop this. Let's start this. And it was a water pill. It was Lasix, furosemide. And we did that. And lo and behold, this gentleman began to breathe better. He began to have more energy. And in 6 months, I said, I am sorry, I'm going to have to discharge you. So we made sure that his primary care physician took up his care, that he had coverage with his health insurance. And then he went off hospice and he did well for about a year. And about a year, he came back on and he said, he was done, and that there wasn't anything else that could be done. And he was on hospice at that time for about 2 weeks. So that is a true description of what can occur. So it requires, hospice Medicare rules require a team approach. And the team approach is the patient is the primary lead of that team, followed by the physician, the nurse, the social worker, the volunteer, family and caregivers, chaplain, home health aide, sometimes a physical therapist. And now of course, some of those volunteers are pretty special. We're having some pet therapy and some music therapy. So those are an important part of the team. Now, part of the Medicare rules I kind of covered was that Medicare, we look at 6 months and then every 60 days. That's part of the Medicare rules. Financially, and I didn't put this on the slide, but we tend to think of Medicare for people my age and older. I'm 68, so 65 and older. And when a person has Medicare like I do, and if I were to go on hospice, by the way, I have a Medicare Advantage. I have Kaiser, and if I were to go on hospice, that Medicare Advantage would revert to straight traditional Medicare that would cover my hospice care. And then if I were to go off hospice because I was too good to be on hospice, it would revert back to Kaiser or my choice of Medicare Advantage. So that's an important thing to understand. If you're under 65 and you're not on disability, then the insurance that you have will follow most likely the Medicare rules because they base it on Medicare for the most part. And people who have been part of the federal government have chosen insurance companies that they are with, and they stay on that insurance during their hospice stay. Just a little bit of work to cover there so you understand. So hospice benefits, as we continue, are nursing visits. And the nursing visits vary by the person of what their need is. The last person I visited as a hospice nurse did not need a visit 2 or 3 times a week. She needed a visit once a week, even once every 2 weeks. And then as time progressed, we increased that to once a week, twice a week. And then towards the very end, which was about 9 months later, we did about a week of every day. So the nursing visits are based on the need of the person. Medicare rules say that we have to do a visit at least once every 2 weeks. Home health aide visits are part of that benefit. They will come and they will help do bathing and do light chores as a sign for a person who is like the person I took care of, getting weaker and weaker, and they can do a few light things. And then as time progresses, they will help with that bath and with making sure they're clean, showered. Medicare social worker is part of the mandate from Medicare, and often people do not understand why they're there, but it is a very important part of the benefit and a part of the team. Chaplain services are also part of the benefit. Nurse available 24 hours, 7 days a week really needs clarification, because this does not mean that a nurse is going to come and stay in your house for 24 hours. This means there's a nurse that's available on the phone 24 hours, 7 days a week. And if something comes up, they answer that phone and they will say, how can I help you? You describe the problem. they will try and help you resolve the problem at home. Now, if the problem cannot be resolved over the phone and you say, I really need a nurse to come out here, even if it's 2 a.m, they will get a nurse to you to help with the situation. This is really important to understand. And if we tried to give a nurse 24 hours a day, Medicare would be sunk 20 years ago. So another benefit of hospice is the medical equipment. And this is important to understand the difference between this and home health. In home health, a doctor may write for a hospital bed, but you're going to have a partial payment on that. A doctor can write for a wheelchair, but at the same time, Medicare will not cover a wheelchair and a walker. The difference in hospice is we can say this person's going to need a hospital bed. They're going to need an over-the-bed table where they can eat while they're in bed. They're going to need a bedside commode. They're going to need a walker and a wheelchair. They need a transport wheelchair so that that family member can easily lift the wheelchair out of the trunk and help that person go see a movie. So those are important things to understand. The oxygen is included in this. Medications that are for the diagnosis are important to understand. That is the medications for pain, possibly for nausea, for shortness of breath. Vitamins are not covered. Over-the-counter medications are not covered. Certain medications that were for other diagnoses besides the terminal diagnosis, the end-of-life diagnosis, are not going to be covered. That can be talked about with the person who is signing you up for hospice, with your primary care physician, and with your insurance company. Supplies are covered that are, say somebody is having trouble voiding, so they are going to possibly need a catheter that helps take care of the urine. That's covered. If somebody has a skin tear, those supplies are going to be covered for wound care. Bereavement care is part of the hospice benefit, and this is important to know because it's for a year and a day. And if a person is, say, I lost my loved one in the next week, and I'm thinking, I'm okay, I don't need anything, that person from hospice is going to call me and say, how you doing? And I'm going to say, oh, I'm okay. And so they'll talk to me a moment or two. And then maybe in a couple of months, I'm going to go, I'm feeling kind of strange and I don't feel right. I can call back and say, I'd really like to talk to somebody. And they're going to follow up with that bereavement care, somebody to be there with me. All important parts to understand of the benefits, also part of the mandate of Medicare. Now, how do we recognize when somebody we love is ready for hospice? Well, there's a few ways to do this. And this is a graph that shows how we often think about death and dying. It's a steady decline. Somebody's been going along doing really well, and then they have a major event and they begin to decline very rapidly and die. So this is the short terminal phase, as we would say. It's a steady decline, and it's usually shorter than longer. If we look at the next slide, this is a slow decline and periodic crises and death. And I often describe this as the CHF, the congestive heart failure patient who has had a heart attack. They were doing okay, they have a heart attack, they go into the hospital where you see the, do you have a highlighter there, James? Go over to that first dip in the graph. They do okay, they're going to the hospital, and that's their decline right there. And then they get somewhat well and they go home, and they have congestive heart failure and they're not doing well. They end up back in the hospital, and you can see they get worse than they were the last time. They get well almost to the point they were last time, and they go home and they're doing this little bit of a steady decline, and then lo and behold, they end up in the hospital again. This is often how it looks for people with congestive heart failure, sometimes kidney disease, other diseases that have slow decline. Next slide, we will see illness trajectory of, and if I had you live, I'd be asking, what do you think this one is? This one is typical for people with dementia, with Alzheimer's. It is that slow, steady ripple in time, and you can just see it happening in front of you. It brings its own suffering and sadness as it's happening, as all of these, but this one is just really, you live with it daily, and it's really hard. So the clinical frailty scale, and this was taken from Dalhousie University years ago, but it still works, is something to keep in mind as we watch our loved ones. And we have trouble saying, no, he's not ready, she's not ready. They're still doing okay. But if we can look at this and say, this is, I see them now, I see the problem. Like I would say I'm very fit. Well, maybe I'm well. And then maybe I'm managing well, but I'm not as well as I was. And as you see, we can go on down to the mild frailty, and we see the use of a walker. And these people often have more evident slowing and need help with their independent activities of daily living. They're typically mild frailty, progressively impaired shopping and walking outside alone. Meal preparation and housework are hard for them. So you can see as this progresses, we have the severely frail, and then the very severely frail, and the terminally ill. Now, as we look at this, some of these diseases that we just talked about, this line previous with the graphs, we might be recognizing that a person's declining, and they might be not willing to have curative treatment. And that's one of the things with hospice is you can't seek curative treatment. So, and they're tired of going to have their blood tested. They're tired of going to the doctor and filling prescriptions all the time. So it becomes a conversation somewhere probably between severely frail and terminally ill to recognize that, to have the conversation with family members. But I'm hoping this might help you understand what it can look like for your loved one, or maybe yourself. The time differs for each person who we're looking at going into hospice. The decision is multifaceted, and it's different for every family, for every person. And it's based on where you live, how you want to live, how much you want to fight that disease that's slowly taking your life. Starting hospice care, though, is not giving up. And it hurts my heart to hear people say, well, they're giving up, they're going on hospice, because it's not a giving up, it's just a changing. It's a changing of emphasis. The aggressive care is to treat symptoms, not aggressive care to cure a disease. So it's a changing of the focus. It's a precious time for sharing, forgiving, and loving. Hospice is such an important time when people take advantage of it. And the services are most effective and supportive when more time is allowed. So instead of it being 2 days, 3 days, even just a week, allowing it to be, if possible, at least 2-3 weeks, a couple of months is so important for everybody involved. And I will say this, and this isn't part of our conversation tonight, but for people who are considering the Death with Dignity Act because of this particular disease they have, it is so important to go on hospice for more than a day or two, more than a couple of weeks, to allow for the family time, to allow for sharing, forgiving, and loving before that act was done. Next slide. Changes to consider in making these decisions are loss of appetite, bowel problems, nausea, vomiting, pain, anxiety, confusion, loss of mobility. Maybe a few of these, maybe all of them, but I really, loss of appetite is one of the big ones because people tend to lose weight as they're approaching end of life. And we don't like it because that's how we spend our life together. I ate dinner early tonight to be here with my husband. I ate dinner with my husband early so I could be here. And that was really important to him and to me because that's what we do with each other. When we travel, we eat together. When we're home, we tend to eat most of our evening meals together. That's our family. When the holidays come, what do? We make big meals and we enjoy each other and eat together. So when a person loses their appetite, it's extremely painful. And it's something to recognize that something's going on and maybe we need to consider this, talk about it. The other one that is huge is anxiety, because anxiety can be an internal process and the person who is approaching death may not realize what's going on. You may recognize the anxiety, may be worth having that conversation because that person, that patient, your loved one may feel something that they're afraid to share with you. And this can be the beginning of an important conversation about what's going on in their mind, that they know what's going on in their body. And then finally, loss of mobility is huge. And it can be the beginning of any end of life situation. And the loss of mobility is connected to the loss of appetite. Immobility is often the main problem, becoming a cycle of suffering. If you have loss of mobility, then you're likely to lose your appetite. And when you lose your appetite or you're still eating and you're not moving, and believe me, moving is important for those bowel issues. And if we're not moving, then bowel problems come up. And then there's constipation. And then there's possibility because I've lost my appetite, I don't feel good enough, and I might be having some nausea from that. Or I might even have not eaten enough that I'm not feeling well enough and I vomit just a little. And now I'm really afraid to eat, so I don't eat. Or maybe I'm afraid of my bowels being more constipated, so I don't eat. Or I'm having bowel problems and I'm really, really constipated, so I'm getting nauseous and I start vomiting. These are all related possibly to immobility. And then there's the pain. So as we age, let me tell you, that pain can come from places you don't even realize, and they don't want to move. And when they don't move, the pain gets worse. And now you want to help them move, but they don't want you to touch them because if you touch them wrong, then they're going to have more pain, and that increases the anxiety. So, and if a person is at home and they really have trouble moving and they're likely to fall when they have fallen, they're not going to want to move because they're afraid they're going to fall. So as you can see, this begins to be a cycle, and the complications add to the problem. So complications are stiffness, joint pain, possibly bed sores, dependent edema where their legs and feet are swelling, and if they have congestive heart failure or problems with their circulation, that can lead to sores. And all of this not moving can lead to pneumonia. I don't mean to be so negative, but it is something that needs to be recognized with our loved ones when immobility is a problem. And hospice can be a help by being a support emotionally, by teaching how to move and have somebody be safe, by bringing in certain medications that can help with some of these issues, and having a guide there through the nurse and the physician. So, hospice provides care that includes recognizing and treating suffering. So, anxiety, shortness of breath, stomach, and bowel issues, and pain. So we're going to take a few minutes and I will say emotional suffering. So we're going to take a few minutes to talk about pain and what we do about that. So the signs and symptoms of pain are grimacing, tenseness and rigidity, guarding, irritability. And I'll have to say, if you have somebody who is not able to talk to you clearly, somebody with dementia, somebody who has Parkinson's and it's so hard to talk, or has just an inability to share, or they don't want to share because they've been an engineer and they don't want to share their, what they're going through because that would just not be appropriate. You can watch and see that sometimes they'll move and they'll grimace. Or maybe they're more tense and rigid than they normally are, Or maybe as they get up, they're holding themselves in a particular way that's guarding so that they're protecting that place that hurts. Or maybe, I happen to have some pain in my thumb, and one day I was in private and pulling up my britches, and I called out, and my husband went, "What was that?" And I said, "That was my thumb just moved wrong suddenly." So it can even be an alert and oriented person who calls out suddenly because it's sharp. So it's something to recognize. Restlessness, rapid heart rate, and blood pressure changes are all nonverbal signs of pain. And then they might tell you about the pain. Then there's this sleeping, maybe an escape from pain. We often think that people are sleeping, they can't be in any pain, but often people try to sleep to escape the pain. And we cannot take sleeping as an okay, they're not in pain. So it needs to be researched. And next slide. So some people, and I'll say this briefly before I start on the myth, some people are stoic and will swear they have no or little pain when their vital signs may be saying something else. Their blood pressure may be up, their heart rate may be fast. And some people actually have higher pain tolerance, and some people actually have very low pain tolerance. And I have a friend who has 0 pain tolerance, I swear. But that is true for a lot of people. So we cannot judge that because you would not have pain, they don't have pain, or because you do have pain, they should have pain. So it works both ways. So I did want to talk about the myths regarding opiates or narcotics. Many people believe that narcotics or opiates decrease respirations, the amount of breathing that we do, and they kill the person. This is not true. The fact is, when properly titrated, the medication does not hasten death. And in fact, I will tell you the story we have in hospice. We use liquid morphine, and we use it for shortness of breath. In fact, morphine was used for shortness of breath before it was ever used for pain. And they discovered, oh, it works well for pain, and people forgot it used to be used for shortness of breath. So we have bottles of liquid morphine that families learn how to give the medication to their family member, little doses. And I had a patient whose family was extremely nervous about the morphine in the house and how much was given. And I remember Dr. Dial coming to meet with them as a family and talking to them about this morphine. And he said, if we gave her the whole bottle, she would not die. She would more than likely throw it up. So we're not there to hasten the death. We're there to help with the shortness of breath and the pain. And if it can be titrated to the right doses, it actually allows the person to remain more active instead of sitting there tight from the pain and not wanting to move and not wanting to think about anything else, or maybe trying to sleep so they can ignore it. Next slide. The myth will cause addiction and physical impairment. Well, the fact is, psychological need is absent when the narcotic or the opiate is being used appropriately and the pain is controlled. So if I don't have to think, maybe I can have that medication in 6 hours. Man, I'm in such pain. I don't think I can wait for 6 hours. What? Oh, wait. Oh, it's only 5 hours. So if people don't have to do that, then they have a relief to live their life and to be occupied with other things. Enjoy their family. Also, proper dosing adjustments prevent fear of experiencing the pain, which can lead to that clock watching and constant fear that they're going to be in pain. And then the next myth is it will be more effective if not given until the pain is severe. Oh, no. It takes more pain medication to get the pain in control than to keep it in control. So if a person has a pain level of 4 and we can medicate them with ibuprofen to keep that pain in control, yay. Down to a 3, 4, if the patient wants a 0, then maybe a little more medication. So figuring out what level of pain that person wants and not allowing it to get to a level 10, 8, 9, 10, even 6 or 7 is important because it's going to take more pain medication, more narcotic to get that pain in control, which is going to add to problems of constipation and confusion and nausea and just more discomfort in the long run. So we want to titrate the medicine earlier than later. And there is no upper dose. People are afraid that if they start it too early, then that it won't be effective when they need it. And there is no upper dose. In fact, medications can be matched to help the medication work and to help that person be comfortable. We can match one narcotic with another narcotic. We can match a narcotic with a medication that helps with anxiety. There are different ways to have medication work together to have the best care possible and still help them have the best life that they can. Will cause physical impairment. Well, the initial sleepiness, which is the physical impairment, does occur, but it usually wears off in 1 to 2 days. And if the pain is controlled, it will allow for increased concentration and mental acuity. Again, people who are in pain are distracted by the pain, and they maybe just really would rather sleep and do nothing else unless their pain's in control. And it allows for more enjoyable life when the pain is controlled. Finally, suffering. Pain is stabbing, burning, throbbing, aching. Those are descriptions for pain. Suffering is sorrow, grief, misery, woe, anguish, emotional ache. It's a different type of pain than physical pain. And it's just as real. And it has meaning for the patient and the family. This author, a medical author, says pain itself does not ordain suffering. It is, in fact, the meaning that is attributed to that pain that determines the suffering. So if a person is so afraid of the physical pain or the act of dying, the suffering they have from that, the sorrow, the grief, possibly the fear, is all different kind of suffering that needs to be addressed and can be helped with the care of hospice, the social worker, the chaplain, the case manager. And I will say the home health aide, because sometimes that's the person, that home health aide is who the person is going to talk to. So hospice is really good at this. Viktor Frankl wrote about suffering in his book, The Meaning of Life, The Search for the Meaning of Life. And he did a lot of suffering in the Holocaust, in the work camps. And he talks about suffering, and if we think about it, sometimes we all suffer, but it is what brings about meaning. And when we have an opportunity, we see somebody who is suffering and that kind of pain in hospice and as a family, it is a time to come together and figure out what do we do to relieve them of that pain and to help them find meaning at this time in their life. And so one of the things I've learned is that we need to be free from the denial and the need to self-protect, to see the suffering in another. So it's up to us to be willing to see that and to see that language in their body, their eyes, their hands, to see their language even, what are they saying? So it's hard, but it is something that hospice can help the family and the person deal with. And often suffering comes out in anger, fear, guilt, loneliness, helplessness. It's often anger is the outward sign of an internal struggle such as fear or guilt or loss of control. And there's the guilt that sometimes in that, not just the fear of their dying, but the guilt that they are dying. And as they're dying, they're a burden to their family and loved ones. And that's part of how hospice can come in and help with that misconception, because they're really not a burden. There's somebody who needs to be loved. The family is somebody who needs the support so that all can have a better, and I'm going to say it, a better death, a better ending, better memories as that loved one is going into eternity. So struggling with the paradox is, and this is why we not only treat the person who is on hospice, we treat the family, the loved ones. And when somebody's in a facility, we support those people in the facility who help care for that person. It's because it's a paradox. We want them to live. If my husband were dying, I want him to live, but I would be exhausted and may feel relief when he dies. This happened with my sister-in-law. I could see it. And she said it when he died. She said, I didn't want him to die, but I'm just so exhausted. And he was suffering so much, and as was she. And the other struggle is the paradox. I want to care for her, but I feel angry at being stuck caring for her all the time. And these are things that hospice can help the family address. So what do we do with all of this? Well, first of all, we need to listen to each other and to recognize in that listening, sometimes it's not being said with the mouth, it's being said with their being, and we just need to pay attention. We need to be calm. We need to remember to hold a hand. And if they can't do anything, we can read to them in hospice. We can play music. And the most important thing on hospice, off of hospice, every day of our life is to be with them and to be with them in the moment of their life. And if a person is dying, one of the best ways to help do that is to allow for the support that can encircle you, come up underneath you, and make this time better. So if you have any questions, I will try to answer.
The first question we have is, what is the first step to take if I want hospice care for my loved one?
The first step you need to do is to have their primary care physician or their specialist write an order for a hospice to evaluate if they are ready for hospice. There are certain criteria that have to be met for all of the end-of-life diagnoses.
The follow-up question is, when is the best time to initiate hospice conversation with my physician?
The best time to initiate a hospice conversation with your physician is actually when a serious illness has been diagnosed, that you not be hospice conversation necessarily, but say you are diagnosed with congestive heart failure, seems to be on my brain. If you're diagnosed with congestive heart failure and you're beginning treatments with that, then there needs to begin to be an open conversation with your physician or your nurse practitioner, PA, that's saying, so this is what I've been diagnosed with. What does this mean for the rest of my life? Begin those conversations so you understand what it looks like. As that picture, that graph I showed you, it's not going to be an even decline. It's not going to be you're going along like this and then die. It's going to be an up and down. What does that mean? Start a serious illness conversation with any serious illness. And this is something that doctors, nurse practitioners, physician assistants are often feel like they can't do, but if a patient, a family member initiates it, then they will begin to do it.
The last question we have, Terry, is, can I choose my hospice provider, or is it assigned by my insurance or physician?
Oh, I love this question. You always, and this is a Medicare rule, you always have the right to choose your hospice. And if you happen to be in a hospital and they decide a hospice for you and you say, I don't want that hospice for my family member, then you can say, I would choose, and right now I would say, please choose Livingston. And so you have the right to choose the hospice. Now, if your physician or the facility that you're in chooses a hospice and you go with that hospice because you're willing to try it and you're not happy with them, you always have the right to change hospices too. And this is also true for home health. You always have the right to say, I'm not happy, I would prefer to have this agency instead. That is your legal right. That it? Thank you so much. And I hope it's all clear. If not, email us.
Thank you everyone for attending our presentation this evening. If you have any other question, please feel free to send it via the chat box or send us an email, and we will connect you with our care transition liaison or Terry herself to answer any of your questions. Thank you once again. Have a good evening. Bye.